Good day, everyone, and welcome to today's webinar, Medicaid Palliative Care Benefits. Before we get started, we would like to review a few technical items to make sure that you can interact with us today. The Q&A button, please click on that and a window will appear where you can submit a question. We'll make sure to try to take as many questions as possible at the end of the webinar today. Recording. We are recording today's session. However, you don't need to worry. Participant lines are muted. And then we will make this recording available on the NASHP website. And the slides will also be available as well. And we want to thank you so very much today for joining this webinar. My name is Wendy Fox-Grage. I'm a senior policy fellow here at NASHP. Next slide. We want to thank the John A. Hartford Foundation for their very generous support and their guidance. And we want to especially thank our fantastic project and program officers, Amy Berman and Scott Bain. As you can see from the slide, we've got a great lineup and a great agenda today. First, you're going to hear from Marcus Exobito. He is with the John A. Hartford Foundation to give us a welcome. Then we're going to go all the way to Hawaii, and we're going to hear from Judy Moore Peterson, Hawaii's Medicaid Director. And then we'll hear from an actuary, Elric Berkman from CBIZ Optimus, and he's going to talk about an actuarial analysis of Medicaid and palliative care. And then I'll come back on and wrap things up, talking about a brand new state institute that we're launching to improve care for people with serious illnesses. And we're hoping that so many of the states who are on this call today will apply for this institute. And with that, let's go ahead and I'm going to take it over to Marcus. Marcus.
Thank you, Wendy. It's great to see you and great to be here with you all to give this a welcome for, I think, what's going to be a really exciting webinar about helping states improve access to palliative care and understanding these incredible resources that we're going to hear about and hearing from Hawaii and what's going on the actuarial side. I don't know about you, but I'm really excited. And so a welcome to you all. Wendy mentioned I'm Marcus Escovedo, Vice President of Communications at the John A. Hartford Foundation. We are a national philanthropy based in New York City, and we work to improve care for older adults. That is our mission. And we organize that work in three priority areas: creating age-friendly health systems, supporting family caregivers, and improving serious illness and end-of-life care. And all of those intersect and are represented on today's webinar. On behalf of my colleagues at the Foundation, you heard Amy Berman, Scott Bain, our Vice President Ronnie Snyder. From all of us at the Foundation, we want to thank NASHP for organizing today's webinar, thank our panelists who are going to be terrific today, and most importantly, each of you in our audience. It's your enthusiasm and passion that will help improve access to palliative care in your states and across the entire country. I want to note a couple of important messages as you think about what you're hearing today. This is just a few of the resources that are available from NASHP under our grant funding that is helping states really press out, push out really high quality serious illness care. So take advantage of all of those resources beyond the actuarial analysis, the state institute that you're going to hear about today. I want to also point you to other resources that we have at the Foundation, and one in particular that will be really valuable to you. It is a new serious illness messaging toolkit that will help you talk to the public and policymakers about palliative care, advanced care planning, hospice, and living well with serious illness. So go to seriousillnessmessaging.org, use that free resource, use what you're going to hear today and all of NASHP's incredible resources. Thank you for what you're doing, and I'll turn it back to Wendy and the rest of the agenda. Thank you all.
Fantastic. And I'm really pleased to introduce Judy Moore Peterson. Dr. Peterson, take it away and let us know what's going on in Hawaii.
Oh, thank you so much for this opportunity to cover this and what we're really active on today here in Hawaii. Next slide, please. So first of all, I just wanted to point this out as, why are we doing this? And it's largely because we have a very fragmented and confusing healthcare system, especially for individuals who have serious illness. They might have gone into the provider and gotten a diagnosis of cancer, and then they're in shock and they don't know what to do, et cetera. And then this is what they're facing. They're facing a healthcare system that thinks about individuals in distinct body parts and not as a whole person who's got all their body parts working together, or within a family context, et cetera. And then this is the healthcare system that they have to navigate. And so they're in no mental state to be able to navigate this. And especially in the world of Medicaid, in which individuals have many, many different challenges in their life that they're already facing, economic insecurity, health disparities of transportation, et cetera, that just navigating this healthcare system for their health and well-being is extremely challenging. Next slide, please. So what are we talking about when we're talking about care for people with complex needs or serious illness? Well, first of all, the first thing I want to do is note that it's not hospice care. So we're not talking about hospice. There is a huge distinction between what we're talking about when it comes to palliative care or care for people with serious illness. And I like to summarize it with this phrase at the bottom. It's living, and the focus and the goal is living as well as you can for as long as you can. Next slide, please. Well, there is a benefit that is in existence that's called palliative care. It is hospital-based. It's inpatient hospital-based. And what we're looking for is, that's just a minuscule part of one's overall health and well-being. And so the concept or the idea behind palliative care is that it's specialized care for people living with serious illness. And it provides that support for themselves and the person, that wraparound support to really help them navigate and have these conversations, and to navigate through and with as they're working through and dealing with the onset of a serious illness. And the other thing, a couple other notes that I really want to call out here is that it's based on the needs of the patient. It's not what the prognosis is or stage of the illness, which is a really big distinguishing factor of hospice. As many of you are aware, hospice is only available once the person receives a less than 6 months from a provider statement, and then it does not include any kind of curative treatment. And for that reason, many people actually forego a hospice care until very, very late in their illness, in which a lot of this care, these conversations would be very, very beneficial to be able to have. And I think this is the concept of palliative care, serious illness, is helping to fill that gap and address that gap. So in Hawaii, as we've been thinking about implementation, we've needed to work through several main topics. One is the eligibility criteria: who would qualify for palliative care, what are the services that are involved, what kind of teams of providers would be allowed, or would we want to be providing this. And then we also are thinking through and developing the payment and the rate methodologies. And the last thing here, and this is the kind of the big thing that where we're at right now, after having done all this work, is that we're working on, we have already submitted a state plan amendment to CMS to be able to cover this as a regular, Medicaid benefit. Right now, it's a bit of a challenge because the description of what it is that we want to provide doesn't neatly fit into any of the 1905A benefits. Those are the Medicaid benefits, the standard Medicaid benefits that we provide. such as home health or hospice or some of these other irregular benefits. So that's kind of where we are right now with CMS, doing a lot of back and forth with them on that. Next slide, please. This is just an example of how it doesn't neatly fit into any of the 1905 benefits. And on the far right-hand side, you see the home and community-based services. And for those people who know Medicaid, you know that those are 1915 or 1115 services that aren't in the, you have to get a waiver to get that, to cover them, and they don't fit in the 1905A. So there's just some crosswork there for you in case folks are interested. Next slide, please. In Hawaii, this is the criteria that we've worked on and developed. It needs to be a severe medical condition, life-limiting, that in which there would be a progressive ongoing decline over time. People can come up with their own definitions should they want to. I'm just pulling up what we have worked on. Next slide. This is the array of services, assessment, the clinical services, care coordination, and communication. I really kind of want to emphasize that last one on the far right-hand side. We think that's where the bread and butter and the most benefit comes from, but it's the whole thing all together. And again, it's based on a care plan and working with the individual and their family, and it's meant to support both that individual again and their family, with them in the middle. Very person-centered. Next slide, please. And these are the providers. Again, this is what we have put together. So a physician, board certified in this related field, registered nurse, clinical social worker, spiritual care professional, child life specialist. We also have strongly encouraged community health workers, pharmacists, home health. So, oops, I have home health listed twice. Sorry about that. Anyway, it's those are the provider and the provider array that we have chosen and wanted to use and put together. And we did all of this work with working with community stakeholders and getting their input, working through many of the, should we do this? Should we do that? What kind of services should we include? What are the eligibility criteria, et cetera? So this was done after a good, at least a year and a half's worth of work with community interested stakeholders, et cetera. Next slide, please. Oh, and there we are. So that's what we're doing here in Hawaii. And let me just go ahead and turn this over to Elray.
Thank you, Judy. Hi, everyone. My name is Elric Berkman. I am a senior manager and consulting actuary with CBiz Optimus. Our work at Optimus focuses on Medicaid managed care rate development mostly. We also have experience developing value-based purchasing programs and assisting states with Medicaid waiver and state plan amendments. Over the past 2 years, I've had the great opportunity to work with the NASHP team and Tori Fields of Tori Fields Analytics, as well as folks from the Hartford Foundation and a number of other people that have tons of expertise when it comes to palliative care, to develop an analysis focused on estimating the impacts that a palliative care benefit can have on a Medicaid program. So I'll be doing an overview of the work we've done so far that helped us produce the actuarial report available on NASHP's website. Next slide, please. So we're just going to touch on the state of palliative care in Medicaid today, then walk through the steps of our analysis and what the results of that analysis showed. Next slide, please. Currently, no Medicaid programs, although I think Hawaii might qualify for this now, offer a comprehensive standalone palliative care benefit. Some states do offer a limited set of discrete services, but the lack of a complete benefit really falls short of providing the member the true intended benefits of palliative care. Fortunately, though, palliative care as a benefit in Medicaid has been picking up steam. The NASHP team has produced several great resources already for states interested in learning more about palliative care. And then there are programs like California that had a Senate bill requirement that the state's Medicaid program establish a palliative care benefit. So for our analysis, the development of the palliative care benefit utilized much of the information that was available from the California Senate bill, including the included services as part of the benefit and the makeup of the palliative care team. Next slide, please. So the actuarial analysis, the methodology here, these are the steps we followed to develop our analysis, which I'm going to cover in more detail over the next few slides here. But it started with identifying the population with serious illness, reviewing the cost of that population, developing a benefit amount for palliative care, determining a savings assumption, and then looking at what potential savings and ROI that could produce. Next slide, please. So what we did is we analyzed data from 3 state Medicaid programs for experience from 2018 and 2019. The first step we took was to look at the prevalence of serious illness within Medicaid populations, for which we grouped 5 broad eligibility categories that reflected populations of similar risk. So for instance, these groupings included children, adults, the expansion or ACA population, disabled enrollees, and then those in long care, generally your HCBS waiver and institutional populations. We looked at the prevalence of each of the illnesses listed here, generally those representing the most serious illnesses, since we are trying to understand the volume of members that might benefit most from palliative care. And what we saw from that, unsurprisingly, is that the disease prevalence is going to be highest among your disabled, your dually eligible, so those eligible for both Medicare and Medicaid, and then your LTSS populations. These, of course, too, generally correlate with your higher cost populations. Next slide, please. So after we established that limitation to Medicaid enrollees with one of those serious illnesses, we conducted what we call a look-back study. And so the intent here was to focus on the highest utilizers of services. And so we identified members that we could go through the claims experience and actually see that they had entered hospice. And we analyzed their experience, the utilization and cost of services prior to them entering hospice. And so we did this for a 3-month, a 6-month, and a 12-month look-back period. So for example, if an enrollee entered hospice in April 2019, the 3-month look-back would comprise their experience from January to March of 2019. And what we notice is there were increasingly high levels of utilization for acute care services like inpatient and emergency department services as members approached that hospice period. So the utilization of the higher cost inpatient and emergency department services increasingly got higher as we went from the 12-month look, the 6-month look, and that 3-month look. And so essentially we wanted to really focus on the higher utilizing population here. And so limiting to that 6-month look back period here, that served as the baseline for costs for our analysis for the target Medicaid population that would utilize palliative care services. Next slide, please. So now that we had established the baseline cost of the population, we wanted to determine the expected cost for the comprehensive palliative care benefit. Again, we largely based this on the services and palliative care team as outlined in the California Senate bill, the benefit materials. So you can see here the list of services and what that palliative care team was comprised of. Next slide, please. We varied wage information across the states that we analyzed using information from the Bureau of Labor Statistics. And on top of that, we included, in addition to the benefit of 20% to account for any additional admin and overhead expenditures. And so based on the expected number of visits by service and the service distribution across the palliative care team, the benefit amounts ranged from roughly $450 to $500 per member per month across the 3 states that we analyzed. Next slide, please. So now that we had baseline costs and benefit cost amount, with effective administration of the palliative care benefit, we know that this will lead to reductions in the utilization of those costly inpatient and emergency department services. So we utilized a couple different sources, which we have outlined in the paper again on NASHP's website, but based on those sources, and the population for which our analysis was focused on, we felt comfortable with the assumptions shown here for expected reductions that we would see in inpatient and emergency department services in utilization of those services. And so we were assuming a 26% reduction on the lower end and then 46% reduction in utilization on the higher end there. Next slide, please. So now putting all of those pieces together across the 3 states that we analyzed, on the lower end assumption, we would expect to see PMPM savings ranging from $230 to $460 per member per month. And that translates to an ROI or return on investment between 1/2 to 1, meaning for every dollar spent on the palliative care benefit, the state administering the benefit would expect to see savings between 50 cents and $1. On the higher end, those savings could reach as high as $1,165 per member per month, or an ROI up to 2.6. So meaning every dollar spent on palliative care benefit would translate to $2.60 saved in total cost. Now, I should note that this analysis for potential savings in ROI is focused on our Medicaid-only populations, meaning we did not include results for the dually eligible populations. The modeling becomes a bit more opaque on that population because of the acute care coverage from Medicare for those dually eligible members, but it remains an area of interest for us that we want to expand upon further in the future. And just as a closing remark here, as an actuary, of course, it's fun for me to work in spreadsheets and look at the numbers, but really what we're trying to do here is offer additional resources that help make this critical benefit more widely available to people with serious illness. We know that healthcare isn't cheap, and Medicaid has its own obstacles to navigate when adding or changing benefits. And we hope that our work continues to provide the resources that help those state policymakers add this as a covered benefit to their Medicaid program. All right, and with that, I will hand it back over to Wendy.
Great, thank you so much, Elric. Fantastic. Next slide, please. And one more. There we go. Okay. Well, Marcus kicked off this call by saying there are lots of resources out there for you, and particularly for states. And so I just wanted to show you where that is. This is a screenshot of our NASHP website. If you see in the lower left, it's nashp.org. And all you have to do is go to topics and click on palliative care. And you can see a number of different resources moving from left to right. We'll do the first, featured content. So the first, and this is just a smattering of the different resources that are out there. If you want to learn about promising practices for other states, you could click on that States Make Progress in Palliative Care. Marcus was talking about messaging and educating the public, and Judy spoke about that as well. She spent a significant amount of time in Hawaii listening to stakeholders and messaging and educating them about what palliative care is and what it's not. That's a resource as well, that middle resource. And then all the way to the right, 7 steps. If you're interested, for those states that are interested in building a community-based palliative care benefit within Medicaid, both Judy and Elric had to kind of go through those steps as well. And that's outlined there on that resource. Going down on the lower level, you'll see that paper that Elric was talking about. You can click on it and read all those numbers there. That's palliative care and Medicaid costing out the benefit. And then probably our most popular feature is we do a lot of interactive maps. If you're interested in what one state is doing in palliative care, you can click on our map. So as an example, there's a map right there that shows all the different advisory task forces in which states in palliative care. And there's some other resources on there as well. Next slide. We've been really fortunate because the John A. Hartford Foundation has funded us for 4 years and another 3 years now. So we're able to make these resources available to states for free. Okay. What I'm really excited about is announcing that we are going to be able to have a 2-year, what we're calling an institute on serious illness for up to 5 states to participate. For those 5 states that want to develop and strengthen policies and strategies to improve access to palliative care. We do have an application process, but we tried to make it as easy as possible for states. And so this is just a listing here with all these bullet points of, some example topics that we could cover, in the Institute. You could in your application, for those states that are interested, you could be interested in one or many more topics. At NASHP, we really like to meet the states wherever they are, and we really want to do what is most necessary for states, what they choose to work on. So there's great flexibility here. But as you heard from Elric, oftentimes when we hear from states, particularly those who are thinking about adding a palliative care benefit within their Medicaid programs, is how much does it cost? And that is an amazing feature of this institute, is that you will have access to actuaries. Elric is one of them, Tori Fields is another, who can help run data reports. They can run the data that you need to be able to make the decisions, for example, that Judy in her state has made with palliative care. Okay, next slide. I also should say we're also very fortunate to work with CAPC, who provides guidance to us as well. Okay, so the point of this institute, and it really is like a peer-to-peer learning opportunity for up to 5 states, is to develop and strengthen policies and strategies to improve access to palliative care, and therefore to improve care for people with serious illness. This is for states. It's for state leaders, for states to learn from each other. And also we can invite and have on the national expertise that sometimes is needed. And then, of course, as I said earlier, we're happy to run all kinds of data depending on what the state wants. Next slide. Okay, so here are some of the concrete things that the 5 states will be doing. They'll be developing a work plan, which is going to be key, right? What key policy and programmatic state priorities they have. And then once they have that work plan, we can figure out what individualized technical assistance that they need. And as I said, it's going to be NASHP staff who's been working on this for years, as well as experts, both national and state leaders in the field. We're going to have 4 virtual workshops for the states to be learning with each other. And then we're going to be also having every other month, the experts will be meeting with each of the state teams individually to work on their work plan and the things. Next slide. Okay. In the application, this is probably the most important thing that I'm going to say is, so the emphasis is on helping states. So we want to make sure that at least 2 state policymakers, 2 state officials or administrators who have decision-making authority are part of the team. And one of those state officials needs to serve as the team lead. Now, the team members can be up to the state. It's totally optional. You could have all 4 members of your team who are participating in this learning opportunity. All 4 could be state officials, or you could have others. You could have somebody from, if you're a state with, for example, an advisory task force. We just talked about that. If you wanted somebody who represents that to be part of this, you could. There's other state staff, there's community-based organizations, there's advocates and other kind of key organizations. Again, we leave it up to the state to have that makeup of the team, but 2 out of the 4 need to be states, and it needs state officials, and it needs to be led by a state official. So to make the application, we used a Microsoft form. We tried to hone in on what we thought were the most important things for the application, and that is, what are your goals and what do you want to do, and a timeline for getting that done, and then what kind of technical support do you most need, and then when you get this technical assistance, how are you thinking you're going to make progress toward these goals? What does success look like, in other words? Okay, next slide. So here's the timeline that we're looking at. And the most important date on the slide is that state applications are due on February 24th. We will then, 2 weeks later, on March 7th, we will notify the states that get to participate, the selected states. And then 2 weeks after that, it's a really quick turnaround time, we'll have our first meeting. And that's when the Institute will begin. But again, February 24th is the deadline, and we're pretty strict about that since we're on a tight time frame. Next slide. Okay, with that, let's go ahead and open it up for Q&A. I know I'm happy to take questions, and I know our panel is as well. David, do you want to take the slides down, and then we'll have our panel all on? The questions are really coming in, so thank you so very much. Okay, Judy, this first question is for you. Does the Hawaiian model provide pediatric palliative care services? And if so, is there a separate eligibility diagnosis criteria that's more applicable to the children?
Yes, and yes. I didn't outline it here, but there is. We included additional serious illnesses that are applicable to for children. I do want to note that there is a distinction for kids, in that if children do qualify for hospice, they do not have to forego curative treatment. It's one of the oddities of the Medicaid program. Nonetheless, we thought that it was still important. We debated it, going back and forth in our team, but we did think it was important to have to make sure that we did not have age limits. And so we do have some additional diagnoses that are specific for children.
Great. Thank you so much, Judy. This next question is to the whole panel. What would your panelists advise other states to do if they're looking to study the merits of a palliative care benefit for Medicaid enrollees? I'm working on legislation in my home state to get a state-funded study done on this topic, and I would welcome any guidance to make this project fly. So, advice.
Maybe we're a bit lucky in Hawaii in that we've been focused on end-of-life care, serious illness for a number of years. But nonetheless, you know, prior to coming to Hawaii, I was actually in Oregon, and it was actually also a really important topic. I think it almost sells itself in the sense that we know that the majority of costs for an individual are at the end of life. And we also know that if you're able to provide care for individuals with serious illness, you know, study after study that the actuaries, like what Tori Fields did for us, what Elric was outlining, it demonstrates that there's a return on investment when it comes to money, but more importantly, the quality of life for those individuals who use palliative care just goes up tremendously, and that's what this is all about. So it's like this benefit and working on this really it sells itself.
Wendy, might I chime in and get your confirmation on this? But I actually saw that question and wondered whether the State Policy Institute would be a great opportunity for this person or anyone considering that they need more data and information, because maybe the kind of technical assistance you'll be offering may meet some of those needs rather than other kinds of academic studies. The other point I would make is to check out an organization Wendy noted, which is the Center to Advance Palliative Care, CAPC. They do have easy to find resources on the literature that is available that Judy just referenced.
Wonderful. Thanks so much. Perfect. Elric, this next question is for you. So we had some questions around, you know, your 3 states, state 1 and 2, and, you know, would cost savings be realized for all of the states or not for states 1 and 2? There's a little confusion.
Yeah, in the paper that we have, a positive ROI, so greater than 0, is indicative of cost savings. So even the 0.8 and the 0.5, those are still indicative of overall savings. Essentially, the savings is greater than the cost of the benefit. But I think related to the other question, you know, this was a pretty focused analysis. There's more details describing it within that paper, but your own state's benefit is gonna be different. And so to the extent that you try to do the same sort of analysis, you just need to modify it as necessary, you know, because it's challenging using claims data. We tried to focus on those that entered hospice because we knew they were the highest utilizers, but really using some sort of functional assessment would probably give you a better idea of those eligible under whatever your state's policy is going to be. And then I think, like Judy said, I think even as you expand the scope of who's eligible, the expectation is that at the very least, this is cost neutral. It shouldn't be costing your state money if it's being effectively administered.
Thanks so much. Okay, another question. My state was able to pass legislation and is in the middle of doing a study with results due this summer. We hope then to be ready to look at how to increase access to palliative care and are thinking of applying to be part of the Institute. would we be considered as ready for the Institute? The short answer is yes. I think you are really ready. It sounds like you're in a perfect position right now, given the legislation and your study. It sounds like you are ripe to be part of the Institute. Judy, given your work in this, over the last couple of years, and I know you were kind of studying it and pulling data tables and all of that. Do you also feel like that's kind of the sweet spot where you're trying to figure out what these kind of crucial decisions around eligibility and benefits and all of that of kind of getting some expertise to help?
Yeah, no, it really is invaluable. And I think that whoever that state is, that they would really benefit from participation. It's a great opportunity.
Fantastic. And then, so Judy, this next question's for you. Does Hawaii limit curative treatment for adult patients receiving palliative care?
Do we limit curative treatment to that? No.
Yes.
It's not limited. It's a curative treatment is available to everyone. I think the reason that we included that we say out loud, and proactively that curative treatment is included is because oftentimes palliative care is confused with hospice care, and hospice does limit curative care treatments and curative care. You actually have to forego. If you go into hospice, you have to say, I am no longer going to be receiving curative treatment. And so to help remove that as a barrier for participation and involvement in this, with this group, palliative care gives you really the opportunity to reach out earlier to individuals who are suffering with serious illness.
Right. And I think that there is so much confusion with the hospice and palliative care. Marcus, to your point of why we need help with messaging, right? Because it gets confused all the time.
Yeah.
Yeah. All right. So Elric, this question is for you around return on investment. Given that return on investment is low for lower risk patients, what is the recommended mortality rate in the patients receiving the palliative care program? And I know we didn't look at mortality rates per se, but diagnoses.
Yeah. Unfortunately, this isn't something that we have really looked into or considered as part of this analysis, but I think it's certainly something we can look into for future research. I would have to kind of think through that piece of it to provide a useful response.
Thanks so much. Okay, Judy, this next one's for you. Will the palliative care providers in Hawaii provide the home health services as part of the benefit, or is home health billed separately to Medicaid and by another provider?
Home health would be billed separately, but the home health team can be part of the team. We actually thought a lot about what kind of services would be included. We're going to be using a bundled payment approach, and we thought a lot about what should be included or not included. And so in the end, we chose to not include home health necessarily as part of the bundle, in part because it's actually already a covered service. We also did not include certain durable medical equipment that is oftentimes used, like oxygen or hospital beds, and that would also be billed separately. So those are the kinds of things that you and your team can think through. We chose to not incorporate it. You may make other choices within your own state.
That was one of the things that when we first started working on this, and I am not an actuary, but working with actuaries, what surprised me is how complicated this was, right? How many decision points there are along the way, right? Like eligibility and services and the providers and what's in the bundle rate and no, home health is separate. I mean, it's amazing how complicated it can get and why you do need all these experts to kind of weigh in and help out, as well as hearing from the community. Judy, can you talk a little bit about that? I know you said a little bit about you heard from stakeholders. Did you have like listening sessions, or how were you able to have people weigh in on the model so that it was truly community based?
No, we have two different organizations, and actually one of them formed during this time period where that is their focus. Their focus is on either hospice or on, people with serious illness. One's called Kakwamau, and the other one is Hui Pahala. Sorry, those are both Hawaiian names that I know it doesn't mean anything for people who don't live here unless you have lived here, etc. But there are two organizations where that is the focus, and so we had many. We had a seminar, an all-day, 2-hour, 3-hour seminar in which we walked through. It was like, okay, this is what we're thinking about. This is the eligibility criteria. These are the providers. These are the this is the criteria for serious illness. Do we want to kids and adults? And so we walked through with the help of consultants like Torrey Fields. We were actually supported by the Stopsky Foundation in that work. So they were very helpful in helping us go through these sort of decision points. We had multiple meetings. We presented the information. We got the draft out there, and then people gave feedback. And so that's sort of how it worked. And over that time period. Thank you for asking.
Yeah. So, and we couldn't have done this also without Tori and Elric and the Hartford Foundation and CAPSI. I mean, it really does kind of take a village of everybody's expertise to put this all together. Judy, I'm just kind of wondering some of the numbers that Elric shared with that showing there's a return on an investment, and at the very, very least, it's cost neutral. Did you find the same thing in Hawaii?
Oh, yeah. Yeah, we did. Some of the health plans, our managed care plans, had already implemented the benefit, and they were cost neutral, but they also have some limitations in how they implemented it. But all the analyses came through as being from a Medicaid perspective with a pretty substantial savings.
Yep. And then Judy, this one's for you too, I think. It's have there been discussions with Medicare Advantage plans or at-risk provider groups that have informed the design of the program?
We have a requirement that all of our managed care plans are also special needs plans. And we have a very high proportion, some of the highest in the country, when it comes to Medicare Advantage or DSNP involvement. I'm sorry, that's designated special needs plans, which that's a special type of Medicare Advantage plan. And we have had conversations with them about how to include this, or how to navigate. And if we include it on the Medicaid side, then what are they going to be doing on the Medicare side to make sure that the savings that it goes to helping the individuals who are receiving this care, et cetera, and that we get that information.
Fantastic. And Judy, during our institute, we would love to have you come and speak with our institute states, since you've been through this, and try how you make these decisions and how you put the process even together. So it's so valuable. For those of you who are on the webinar, if you have any questions after this webinar, as you're working on your state applications, let me just give you my email address and feel free to email me and reach out, because I know we've shared so much information, and sometimes when you're in the application, then a question will come up. So once again, I am Wendy Fox-Grage. I work on the NASHP staff. My email for any questions, it's wfgrage@nashp.org. Elric, Marcus, or Judy, any last? Oh, thank you so much, Salam, for putting my email in the chat. That was probably much more efficient than me calling it out. Thanks so much. Any last comments from our panel? You guys have been amazing and fantastic.
I'll give one quick closing thought, Wendy, which is that and behind all this, the great work that Judy's leading in Hawaii and that all the partners are involved in, I think there's a real opportunity here to advance equity in healthcare through this work. As we think about improving access to high quality, serious illness care, and in particular palliative care, we know the data is clear that certain populations are not getting that access. And it strikes me that what Hawaii and the other states that you're involved in at NASHP can be doing is really taking that issue head on through this kind of work. So I just want to plant that seed, see how that might integrate with your state's goals around equity, and fit it that way as well.
That's a great point. And it also ties into, Judy, I know we've talked about this before, that it also ties into person-centered care. And listening to people's goals and what they want. And so I think that it's such a powerful benefit that people just have, hasn't been in existence yet. It's what we all, when you explain what it is, we go, oh yeah, we want that. So anyway, Judy, last comments.
Just that I think, I mean, you could probably tell that I'm very passionate about this work. I do think that is actually also needed, is that you do need to have leadership who are committed and leading from the top. And I'm actually happy to have any conversation with anybody about the benefits and and sharing why we are so passionate about this work here in Hawaii, and would really encourage everybody to participate if you're able to, and pursue this if you're able to.
Fantastic. And Ulrich?
Just, this is still a relatively new benefit being offered in Medicare. There's no standard being offered, so that's why it's such a challenge for states here. So, we're just happy to continue to move this forward and offer resources for interested state policymakers.
Great, fantastic. I'm going to end by answering one of the biggest questions we've received, which is, are you able to receive a copy of this webinar? And the answer is yes. We've recorded the webinar. We also have the slides. We will make that available on our website as soon as we possibly can. So yes, it will be available. And with that, I want to thank our speakers. I want to thank our participants for joining. I want to thank my coworkers, Salam and Ella, and David, our Zoom operator, for making this go so smoothly today. And also, I want to let you all know that at the end of this webinar, you will receive a survey, and we're really hoping that you fill out that survey for us and give us that feedback that we so need as we have this series of webinars in palliative care. And with that, I want to thank so very much. Thank you, Ulrich. Thank you, Marcus. And thank you, Judy. Thanks so much, participants. And we hope that you all will be applying to our state institute.
Thank you. Aloha.
Thank you.
Thanks so much. Take care.
Thank you.